in our state, our city gets benefited. Okay. Our ISA, India Society of Anesthesiologists, Gujarat State Branch President, Dr. Kandoi sir is with us. Vice President Dr. Tarun Waghela is with us. GC member Dr. Jayesh Bhai is with us. I am also a GC member, Dr. Mangal Dave. And I welcome you all. I welcome Dr. Vanda Madam, Dr. Jigisha Madam, Dr. Vrinda Madam from PDU Medical College, Rajkot. And resident students, Dr. Dhanashri Chaudhary and Dr. Rishabh Mehta, who both are from PDU Medical College. Kandoi sir, please continue.
Okay, thank you, Mangal Bhai, for very nice introduction and very nice topic to start with. This is our first CME, online CME in this year, and I welcome all of you for that. And Mangal Bhai and all, you have arranged everything in a nice matter. I welcome Dr. Tarun Waghela, yeah, all GC members, all national GC members, and our secretary, Dr. Atul Gandhi, also whenever he will come. Now I hand over to Dr. Mangal Dave to start the CME. Okay,
yes.
sir.
Thank
Okay,
you,
you
sir.
can continue.
Dr. Kanvi from Junagadh is also with us. Dr. Kanvi Vania is head of Department of Anesthesia, Government Medical College, Junagadh. She is also has joined us. And Dr. Vrinda will coordinate everything with the students and the examiners.
Hello.
Dr. Vrinda, please.
Yes, sir. On stable.
मोहिनी है
वहाँ पे
मैं उनके दोस्त बोल रहा हूँ
फरहान से अब हम सोचा था ना शब्द तो जो कहने
કેસ પ્રેઝન્ટેશન કરવા માટે ડાયરેક્ટ આપણે રેસિડેન્ટને ઇન્વાઇટ કરવા છે એવું કરવું છે ડોક્ટર who is going to present first, Dr. Dhanashri?
Yes, sir. I'm going to present, sir.
Okay, you may start with your case. Done.
Okay, sir. I'll start.
our screen sharing
Yes. Good evening to one and all present. I'll start with the case presentation, sir. 55-year-old female patient residing at Upleta, coming from lower socioeconomic class, came to PDU hospital OPD with the history of midline neck swelling since 12 years. History of present illness, she complained of midline neck swelling since 12 years, which was painless, firm in consistency, and gradual in onset, and progression from pea size to the lemon size and orange size in the front of the neck, which moves with deglutition. Other complaints, patients also complained of breathlessness, which was exaggerated in lying down position and relieved in sitting position. Patient also complained of weight loss since 4 months and with reduced effort tolerance and cannot climb more than one flight of stairs. There is no history of pain over swelling, hoarseness of voice, difficulty in swallowing. There is also no history of heat or cold intolerance, diarrhea, constipation, headache, tremors, sweating and palpitation, diplopia or blurring of vision. Past history, there is no history of any comorbid conditions or tuberculosis, epilepsy or cardiac diseases. There is no history of previous surgery in the neck or any radiation to the head and neck region. There is no history of any drug allergy or thyroid related medication. Personal history, patient has a vegetarian diet with good appetite. She has difficulty in sleeping in supine position, but she is comfortable in left and right lateral decubitus, and there is no history of addiction. Menstrual history, she is a multi-para with live 2 children. She attended menopause 12 years ago. There is no significant operative or family history. From now,
I will be presenting the examination part. So after explaining the procedure, informed consent was obtained and patient was examined in a well-lit room in sitting position. Patient was moderately built, conscious, oriented to time, place, and person. Patient has a height of 150 centimeters, weighing 55 kg with a BMI of 24 kilogram per meter square. Skin of the hand of the patient was warm and moist. Patient was afebrile, pulse 88 per minute in right radial artery and is regular with adequate volume and with no radial or radiofemoral delay with no apex pulse deficit. Patient has a blood pressure of 110 by 80 mm of Hg in sitting position in left brachial artery. Patient was maintaining saturation of 98% on room air in sitting position. Patient had a respiratory rate of 16 per minute, which was regular without the use of accessory muscles and was thoracoabdominal. Patient has no pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema of pretibial region or Angos veins. Vacant spine, no abnormality was detected. Functional capacity, the NYHE of grade 2. On airway examination, there was no gross maxillary or facial deformity. Both nostrils were patent. Oral and dental hygiene was good with no loose tooth or artificial dentures. Mouth opening of 3 fingers with MPG grade 2. Tongue was normal in size with color grade class A. Upper lip bite test was grade class 1. Inter-incisor distance was more than 3.5 centimeters. Patient had a neck circumference of 53 centimeters with restricted flexion of neck movement. Higher mental distance cannot be assessed since there was a large thyroid swelling. Thyromental distance cannot be assessed and sternomental distance was 12.5 centimeters. Cricoid cartilage was not palpable. All the thyroid eye signs were absent. On local examination, on inspection, swelling is situated in midline of neck, extending bilaterally up to 9 centimeters, above up to thyroid cartilage, below up to suprasternal notch, measuring about 9 into 8 centimeters. Swelling has smooth surface with normal overlying skin. Swelling moved with deglutition and not with protrusion of tongue. There was no visible dilated veins over the swelling and the chest wall, and there was no sinus fistula scars over the swelling. On palpation, temperature of the swelling was normal. Swelling was non-tender, size of 9 into 8 centimeters, nodular, with smooth surface and firm in consistency and mobile. Retrosternal extension of the swelling was ruled out with retrosternal extension of the swelling was ruled out with palpation of lower border of swelling with deglutition. On Lahey's method, lateral borders were palpable. Barry's sign is negative. Kocher's and Paventer's sign is negative. Cervical lymph nodes were not palpable. On percussion, there was a resonant note over the manubrium sterni. On auscultation, there was no vibration heard over on auscultation. On systemic examination, bilateral air entry and equal was present. Upper air examination was normal with normal elliptical shape of chest with bilateral equal vesicular breath sounds present with thoracoabdominal type of breathing. In cardiovascular system, precordium contour was normal. Apex was not seen. Apex weight palpable with no sternal heave and normal heart waters on percussion. And on auscultation, S1, S2 was heard with no murmur. So on the basis of examination and history part, our case summary, a 55-year-old female patient with present with 9 into 8 centimeter midline neck swelling, which increased gradually over 12 years, presented with complaint of breathlessness, weight loss, and was posted for total thyroidectomy.
How can you proceed with your probable diagnosis for the confirmation? Which investigations are required?
Yes, ma'am. We have pre-anesthetic checkup was done, for which all the required blood investigations were done with ECG and chest X-ray. X-ray neck, anteroposterior and lateral view showed tracheal deviation, and CT scan showed large soft tissue density with size of 101 into 100 into 180 mm arising from right lobe of thyroid, involving isthmus, and left lobe was abutting the trachea. No evidence of retrosternal extension was present, and the lesion was adherent, involving right lateral wall of trachea, displacing it towards the left, ma'am. All the hematological investigations were within normal limit. TSH profile showed that patient is euthyroid, ma'am, and on indirect laryngoscopy, bilateral vocal cord were normal and mobile, ma'am. So after taking the detailed case history and clinical examination with required investigation, we have a probable diagnosis of multinodular goiter in euthyroid state, ma'am. Ma'am, can I proceed with the management part?
No. Janashri, so what is the age of your patient?
Ma'am, my age of my patient is 55-year-old female.
And so what is the importance of age for the goiter?
Yes, ma'am. According to age, thyroid swellings present in the different age groups, ma'am. In puberty or in adolescence age, we see simple nodular goiter due to increased demand, ma'am. This happens in the same case as that of the pregnancy, ma'am. Sometimes in puberty we also see papillary carcinoma, ma'am. In middle age group, ma'am, there is a toxic thyroid toxic adenoma, ma'am. Also, Hashimoto's thyroiditis is seen, ma'am. Also associated with, ma'am, follicular carcinoma. And in old age people, ma'am, we can say toxic multinodular goiter, anaplastic carcinoma, ma'am.
Okay. And what about the socioeconomic status of your patient?
Yes, ma'am. My patient belongs to the lower socioeconomic class, ma'am. Thyroid swellings, usually the patients are of lower socioeconomic class, ma'am, because of illiteracy rate and the iodine content or the iodized salt, ma'am. They are not able to have adequate amount of iodine, ma'am. According to IDA, the 150 microgram per day of iodine should be given to the adult, ma'am.
Okay.
Okay. So, can I ask a question about breathlessness? What is the,
Yes,
am I audible, Dhanashri?
yes, ma'am. Yes, ma'am.
Okay. So, you have said that patient is having NYHA grade 2. So,
Yes,
what
ma'am.
do you mean by NYHA grade 2, and how will you classify different different grades of dyspnea?
Yes, ma'am. Ma'am, there are MMRC grading scale for dyspnea, ma'am, which includes from zero to
What do
4,
you
ma'am.
mean by MMRC? What do you mean by MMRC?
Uh, Ma'am, right.
So there is a difference between
Modified.
MMRC and NYHA, right?
Yes, ma'am.
MMRC is
Modified.
different from NYHA.
Right, yes, ma'am.
Do you
New
know?
York Heart Association, ma'am.
Yes, it is New York Heart Association, and MMRC is,
Mm,
it is
Modified.
self-reported questionnaire by Modified Medical Research Council, right? So it is according to the limit of limit in the work due to breathlessness, which is self-reported by patient, while NIHA is reported by, means assessed by clinician. So
clinic.
your patient is having,
Ma'am, my patient is having, ma'am, NYHA grade 2, ma'am, and
okay,
ma'am, MMRC grade 3, ma'am. Hmm.
okay, okay. So what is the importance of this breathlessness in case of thyroid?
Yes, ma'am. My patient is having, ma'am, a huge thyroid swelling, because of which she is having breathlessness, ma'am. Breathlessness is because of the huge thyroid swelling, which is causing compressions and symptoms, ma'am. Because of like compression, ma'am. Because of that, she's comfortable in lateral decubitus and left lateral decubitus, and in supine position, as thyroid swelling is compressing the trachea, which is causing dyspnea, ma'am.
Okay, so
It
it
can
is one of
also,
the compression signs of compression, right? Okay.
yes, ma'am.
Dhanushri, what are the differential diagnosis of midline neck swellings?
Yes, ma'am. It can midline neck swelling can be, ma'am, congenital like thyroglossal cyst, or it can be also because of thymoma, ma'am. Dermoid cyst can be there, lymphoma can be there, ma'am. Cervical lymph nodes can be palpable, ma'am, or it can be thyroid swelling also, ma'am. Or Ludwig's angina if infective, ma'am, or thyroiditis, ma'am.
Okay. Your patient belongs to which area of Saurashtra?
Ma'am, Upleta, ma'am, in
So is
endemic
it
area.
any endemic area for iodine deficiency or anything?
Mm.
Are
Yes,
you
ma'am.
aware of the
Upleta
iodine deficiency areas in Saurashtra?
and ma'am,
Okay, okay. It is an endemic area for iodine deficiency. Okay.
And
Okay.
there are various areas in Saurashtra
How will you
region
assess
which
for
are
the trek?
endemic.
Hello,
Uh,
Tanshi.
yes, ma'am.
Yeah, you have told that swelling is moving with deglutition.
Yes,
So
ma'am.
can you tell me which are the other swellings that also moves with deglutition?
Yes, ma'am. The swellings which move with degglutination are thyroglossal cyst, ma'am, thyroid swelling, ma'am, thyroid swelling with pretracheal, whatever swellings are involved in pretracheal lymph node, pretracheal fascia, ma'am, that is cervical lymph node, which can also move, ma'am, and dermoid cyst, ma'am, and thymic swellings also move with the degglutination, ma'am, degglutination.
And which are the other swellings that moves with the protrusion of tongue?
Yes, ma'am. Thyroglossal duct cyst, ma'am. They move with the protrusion of tongue because of their connection with foramen cecum and thyroglossal duct, ma'am. They move with the protrusion of tongue, ma'am.
Okay.
कल नवरात बैठा थे
Sorry, sir.
And how will you assess for tracheal deviation and compression?
Yes, ma'am. On examination, ma'am, we can see tracheal deviation by trail sign, ma'am, by which we trace the trachea by placing the two fingers, index finger and ring finger, on the sternal notches, and with the middle finger we examine for the direction of the trachea going. This is one of the method of palpation, ma'am. And and for compression, we have the test which is known as Kocher's test, ma'am, for which we compress bilateral lateral lobes of the thyroid, ma'am. And if stridor is present, then it indicates that there is compression of trachea, ma'am. And if for investigations further, if we go, then we can do cervical X-ray neck, ma'am, in AP and lateral view, ma'am, and also for CT scan, ma'am.
Okay. So find in X-ray and CT scan.
Sorry, ma'am.
What will you find in X-ray and CT scan? What is the diameter? You
Uh,
will see the narrowing. You are saying that this is narrowing of the trachea.
Yes, ma'am. If there is narrowing of the trachea, we can see the first of all in X-ray lateral, ma'am, we see the shadow of the thyroid gland, ma'am, which suggests that there is compression, ma'am. The trachea can become scabbard trachea, ma'am.
Okay. Rishabh, what is axillary thyroid and how is it different from ectopic thyroid?
Well, axillary thyroid's masses are present on the anatomical uh, a- anatomical landmark, which from the developmental in the embryological, where from foramen cecum, the thyroglossal duct uh, is reached up to thyroid cartilage. So, ma'am, in that area, if there is any thyroid mass, if any thyroid tissue, that is called an axillary thyroid, and if it is not present in the anatomical route of descent of thyroid gland, then it is ectopic thyroid.
Okay. And how do you differentiate between a goiter and a hyperplasia of the thyroid?
Ma'am, since it can be a tissue diagnosis in which goiter is basically hypertrophy of follicular cells, and in hyperplasia, there is a number of follicular cells are increased.
Okay. Can you describe the methods of palpation of thyroid and how will you diagnose the retrosternal extension of the thyroid?
Yes, ma'am. Different methods of the palpation of the thyroid. There is a conventional method where the examiner stands behind the patient and thumbs are placed at the nape of neck, with uh, with slightly flexed neck of the patient, and with four fingers, the two of four fingers of the each hand are placed at the both lobes of the thyroid, and thyroid is palpated. And for diagnosis and for the retrosternal extension, we check for the to locate to palpate the lower border of thyroid, and which we can ask the patient to deglutination, and we can see the thyroid lower border of the thyroid are touching our index finger, and rest other tests are rest the patient to raise both the arms up to the ear level, and ask the patient to sustain this position until the patient is experiencing any facial flushing or visible dilated veins, or
Can you elicit the eye signs in thyroid patients?
yes, ma'am.
Hyperthyroid
they,
patients especially, yes.
listen, there can be various thyroid eye signs in hyperthyroid patient. Basically, these eye signs are present more commonly in the primary hyperthyroid patients. Uh, wh- First sign is von Grafé sign, in which we ask the patient to look downwards, and in down gaze there is upper lid retraction. And next sign is Mobius sign. We ask the patient to follow the finger from a distant point to the nearer point between the two eyes at the level of root of nose, in which patient is unable to converge the both the eyeballs. Next sign is Starvik sign, in which a patient has infrequent blinking of the eyelid. And in when Joffre sign, there is absence of forehead wrinkling on upward gaze, and there are exophthalmos present.
Okay, so why there is all eye signs are present and why there is exophthalmos in hyperthyroid patients? What is the reason behind it?
Well, in Graves' disease, since it is an autoimmune disorder, the autoimmune antibodies are present in the circulation, and TSH receptors are more present in the muscles of eyeballs, in which it produce the more amount of glycosamine glycans. So soft tissue mass behind the eyeball is increased, and these eye signs are.
Okay. So what are the system you will ask, you will see for the patient? One is eye signs, others are
So, in other way, what are the difference between primary and on the basis of sign symptoms and clinical examination? Can you make out whether it is a primary thyrotoxicosis or secondary?
Ma'am, are you able to hear us, ma'am?
Yes, you are audible.
Okay, sir.
Please answer.
Uh, Thyroid eye cells, exophthalmos.
We just got disconnected, but we can join by our mobiles. What type of tremors does your patient have? Does your patient have tremors?
No,
Dhanashri?
ma'am. Our patient doesn't have tremors, ma'am. But in case of hyperthyroidism, ma'am, we can see fine tremors, ma'am, in the patient. If we
Okay.
examine, ma'am, we can examine it by telling patient to put the hand forwards, ma'am, and
Okay.
all the fingers should be separated, and then we can keep a paper on the bilateral hand, ma'am. If the paper gets shaky, then the tremors are present, ma'am. Fine tremors are there.
Okay, okay. And what about the tremors of the tongue? Do you have any sign for it? Name of the sign for the tongue tremors? Okay, we'll go on to the next question. Importance of sleeping.
Dhanashri, what is the importance of sleeping pulse rate?
Yes, ma'am. Sleeping pulse rate we usually see in thyroid patients, ma'am. When the hyperthyroid patients are anxious, ma'am, due to which their baseline pulse is whatever we record is higher. So whenever they are sleeping, ma'am, we can record their baseline pulse rate. Or, ma'am, they are divided into three, ma'am: mild, moderate, and severe. Mild is less than 90, ma'am. Moderate is 90 to 110, and severe is more than 110, ma'am. There is criteria for this, ma'am. The patient should not be on beta blockers, even if he's taking anti-thyroid drugs, ma'am. And it is usually recorded between 2 a.m. to 4 a.m. in early in morning when the patient is in deep sleep. Parasympathetic system is active, ma'am. Vagolytic action is at maximum, ma'am.
Okay.
Your patient has normal thyroid function test, right?
Yes, ma'am.
Yes.
So what is the importance of thyroid function test TSH T3 and T4?
Ma'am, pre-operatively, if we do thyroid function test, ma'am, TSH levels are the primary test, ma'am, which we do, because, ma'am, we can detect if the patient is a hyperthyroid or hypothyroid or euthyroid, ma'am. T3 and T4, ma'am, we have total T3 and total T4, ma'am, and free T3 and free T4. Nowadays, we do free T3 and T4, which are there in peripheral circulation, ma'am. Free T3 is uh, more potent than free T4, ma'am. And if T3 and T4 values are increased with decreased TSH, ma'am, we can say that it is hyperthyroidism, ma'am. If TSH values are more, then we can see that it is hypothyroidism, ma'am. There are two more thyroidism, ma'am, subclinical hypo and hyperthyroidism.
Okay.
In which TSH levels are, ma'am, decreased or increased, but ma'am, T3 and T4 levels are normal, ma'am.
Okay. So what is the difference between T3 and T4?
Yes, ma'am. T3 is, ma'am, more metabolically more active, and ma'am, it is more potent than T4, ma'am. T4 gets peripherally converted in liver, kidneys, and skeletal muscle to T3, ma'am. T3 is less protein bound, ma'am, whereas T4 is more protein bound, ma'am. And T4 is more protein bound, and in periphery, ma'am, whatever the tissues utilize T3, ma'am. And T4 is produced more in 90% by the thyroid gland, and T3 is produced only 10%, ma'am. It is usually 8 microgram per day, and T4 is 90 microgram per day production, ma'am.
And
Which
what
means
about the
peripheral.
half-life of T3
Yes,
and
ma'am.
T4?
T3's half-life is, ma'am, 1.5 day, whereas T4's half-life is 7 days, ma'am.
So what is the importance of being euthyroid patient before the any intervention or surgery? What do you mean by euthyroid, and what is its importance for being euthyroid?
Yes, ma'am. In euthyroid, ma'am, TSH parameters is between 0.4 to 4.1, ma'am, whereas T3 and T4 are, ma'am, 0.9 to 1.8 and 2.3 to 4.2, ma'am, for T3, ma'am. These are the normal parameters. If there is a decrease or increase in TSH, then it can cause hypo or hyperthyroidism, ma'am. If we are taking the patient for elective thyroidectomy or any other surgery, ma'am, intraoperatively the patient can go in thyroid crisis or myxedema coma. So preoperatively, it is important for us to stabilize the patient's TSH profile and make the patient euthyroid for 6 to 8 weeks, and then post surgery, ma'am.
So ideally, you should give answer like patient should be clinically and laboratorically should be euthyroid, right? If it
Yes,
is
ma'am.
only T3, T4, you are considering only lab test, it is not right. You have to consider also clinically there should be no signs and symptoms of any thyroid, means hyperthyroidism. Okay.
Okay. Yes.
Dhanashree, what is the clinical importance of subclinical hypothyroidism and subclinical hyperthyroidism?
Yes, ma'am. In subclinical hyperthyroidism is not as common as subclinical hypothyroidism, ma'am. In subclinical hypothyroidism, ma'am, T3 and T4 levels are normal, but TSH level is, ma'am, less than, it is between 5 to 10 microgram, ma'am. If it is, subclinical hypothyroidism usually do not present with any signs and symptoms, but if signs and symptoms are present, we have to treat it, ma'am, by waiting for the period of 6 months, ma'am. Every 6 monthly, we do TSH profile, and we look for signs and symptoms, ma'am. If present, we have to medicate, ma'am, with thyroxine. If not, ma'am, we can wait for,
Okay, you can
there is
wait.
no need to give treatment, ma'am. We can wait.
Okay. And what is the clinical importance of low volume loops? How will you clinically interpret?
Yes, ma'am. Ma'am,
The
flow.
volume loops. The flow volume loops are the simple tests which we obtain from the pulmonary function test. in which we can see whether the obstruction is variable or fixed, whether it is intrathoracic or extrathoracic, ma'am. In our patient, there was no intrathoracic invasion or intrathoracic obstruction. In our patient, there was fixed airway obstruction. So we will get on inspiration and expiration loop in both. We will see the flattening.
So in all patient, you will do the PFT or flow volume loop, or which patients you will do this? In your patient, it is a huge thyroid swelling,
Yes,
or you
Yes,
are
ma'am.
suspecting the retrosternal goiter.
Retrosternal.
Then you
Yes.
are
Yes.
then you have to do the flow volume loop examination. Okay.
Yes, ma'am.
Can you describe the other associated autoimmune disorders of thyroid gland associated with thyroid gland?
So there are endocrine disorders associated with thyroid disorders. One is MEN 2A and other is MEN 2B. And in MEN 2A, ma'am, there is medullary carcinoma of thyroid with pheochromocytoma and parathyroid hyperplasia. In MEN 2B, there is medullary carcinoma of thyroid, pheochromocytoma, and mucosal neuromas, and with marfanoid habitus is sometimes present.
Mm, You have told one is flow volume loops to rule out the obstruction. Any other simple tests to rule out the obstruction?
Yes, ma'am. We can do, ma'am, Koch's test.
Just test. How
And
will you
ma'am, we compare the bilateral lobe of thyroid, we will look for
No.
slider or noisy sounds.
Another test is expiratory time, right? You have to put a ballop stethoscope and
Yes.
you have to measure if it is more than what is normal expiratory time? It is 3 to 4 seconds. So if it is more than 6 seconds, then there will be means you suspect you can suspect the obstruction. Okay.
Okay.
So now what will be the medical management options in case of thyroid swelling?
Ma'am, first we have to do hematological investigations in which we specifically do thyroid function tests.
No, medical management. I am asking about medical management.
Yes, ma'am. If my
What are the
patient is
options available for the medical management?
Yes, ma'am. Ma'am,
Ma'am.
if the patient is
If my patient is hyperthyroid, we will go for antithyroid drugs, ma'am.
Yes.
Antithyroid drugs are thioamides, ma'am, propylthiouracil, methimazole, and carbimazole, ma'am. Out of which, ma'am, these drugs, ma'am, inhibit thyroid peroxidase hormone, and propylthiouracil have extra edge with which inhibits the peripheral conversion of T4 to T3, ma'am. After thioamides, ma'am, we will have propylthiouracil has also got the advantage of not crossing placenta, which we can use in pregnancy, ma'am. Hyperthyroidism associated with
Yes.
pregnancy. And ma'am, side effects includes ma'am, joint pain, ma'am, jaundice, ma'am, and granulocytosis, ma'am, and leukocytopenia, ma'am. Whereas next drug goes with
Yes.
iodine, ma'am.
Yes.
Iodine are Lugol's iodine and saturated solution of potassium iodide, ma'am. Lugol's iodine is, ma'am, 5% solution of iodine in 10% potassium iodide, ma'am, which each drop of the Lugol's iodine contains 8 gram of 8 mg of iodine. So we can prescribe iodine 5 to 8 drops, ma'am, per day. And saturated solution of potassium iodide, ma'am. Each drop consists of 50 mg of iodine per drop. So we can give 3 to 4 drops per day. There is one disadvantage, ma'am, that if we continue iodine, ma'am, for more than 7 to 14 days, ma'am, then there is dysregulation of sodium iodide symporter, which causes the thyroid escape, ma'am, which gives you jot-based of phenomenon, ma'am. And iodine
Yeah.
has some side effects like iodinism, ma'am. There is angioedema, swelling of salivary glands, ma'am. But iodine
What
preoperatively
are
is given.
the advantages of giving iodine? What are the
Yes, ma'am.
advantages?
Preoperatively, if given 7 to 14 days before, ma'am, it can decrease the size of gland and also the vascularity of gland, ma'am, and it inhibits the iodination. So it inhibits organification of the
Yes.
in synthesis.
What are the
Then, ma'am,
other options?
yes, ma'am. Then there can be iponiates, ma'am, which includes radio contrast, like, ma'am,
Iron.
dietrazole. And ma'am, next is radioactive iodine 131 we use for treatment, ma'am, which has 0.5 mm to 2 mm tissue penetration, ma'am. It destroys the thyroid gland, ma'am. It is contraindicated in pregnancy, ma'am, and mostly used for neoplastic lesions, thyroid swellings.
Yes. Beta blockers you have not mentioned.
Beta blockers, ma'am. Non-blockers. There are two coming up.
Sympathetic overactivity.
Which is drug of choice in beta blocker?
Propranolol, ma'am.
Non-selective
Non-selective
beta
blocker. Because it blocks the peripheral conversion of photo.
Why? Yes.
Ma'am, it also has advantage of.
It is an added advantage of the.
Yes.
Yes. And steroids also. And sometimes physicians have steroids also. Okay.
But I do not want to claim sufficiency.
So what is in hyperthyroid patient? What is a steel induction? You know, steel induction means.
Ma'am, in the past days when there was no much medication or anti-thyroid drugs was not present, to overcome the anxiety which is already present in a hyperthyroid patient, to acclimatize to the operation theater environment, we used to bring the patient every day for 3 days before or taking into operation theater on the planned OT table. So patient is already acclimatized with the operation theater environment, and patient is given placebo, some D25% solution. And on the day of surgery, patient is comparatively less anxious.
Okay. So if you are posting this patient for a thyroidectomy, your patient is, and so what are the pre-operative preparation you will do for the patient and in the operation theater?
And since there is a large swelling, and we suspect tracheomalacia, so we will go for awake fiber optic intubation, for which we will prepare the oral and the nasal airway with first we will use the viscous gargles lignocaine 2% and lignocaine 2% and 4% lignocaine nebulization, and we will use lignocaine 2% or atomizer for nasal or oral spray.
In operation theater, we will keep a difficult airway cart ready, ma'am, for which we have 4 drawers, ma'am. First drawer includes all the tracheal intubation, ET tubes, ma'am, laryngoscope blade, and handles, ma'am, steel it, ma'am. And second drawer includes all the supraglottic airway devices, ma'am, with intubating LMA and second generation supraglottic airway device. Third drawer includes, ma'am, oral airway, nasal airway, with airway exchange catheters and suction catheters, ma'am, and face masks. Fourth drawer includes the things for surgical airway, ma'am, cricothyroidotomy and tracheostomy, ma'am. There are also side drawers. Side drawers have we keep fiber optic bronchoscope, ma'am, fibroscope, ma'am.
And,
So, is your
okay, and what
patient is
about
having?
Okay.
Jigishabin, is the patient is having a retrosternal extension? No,
No,
no
ma'am.
retrosternal extension. Then why you want to go for fiber optic? Is there
Ma'am,
any
because
other?
our swelling. Yes, ma'am. There is tracheal deviation, and our swelling is huge with long history of long-standing swellings, ma'am. So we can
It is okay,
have.
but patient is not having any retrosternal extension, right?
Yes,
Yes,
ma'am.
ma'am, we
So,
can go for conventional laryngoscopy also.
so you can proceed with inhalation induction, and if it is possible to ventilate the patient, you can use muscle relaxant, right?
Yes, ma'am.
So if it is
After
okay.
chest
It
copy,
is
she
used
can do.
thyroid. Hmm. It is
Conventional.
okay. It is used thyroid, but you can proceed with inhalation induction and then followed by, if ventilation is possible, you can give muscle relaxant and do the, and before that, important findings, important investigations for the airway assessment we have missed, right? What are the important investigation for the airway assessment before inducing or before planning the mode of induction and mode of induction, right? What are the important preoperative assessment tools?
Anyways, so what are the assessment tools? What we are doing? How will you assess before?
Ma'am,
So it is important
yes,
for
ma'am.
the
We'll
planning
have
of induction.
first.
That's why I'm asking. Yes.
First of all, we'll see mouth opening of the patient, ma'am. If a malam patti
These
grade
are the
3.
traditional methods you have done all, right? Mouth
Yes,
opening,
ma'am.
malam patti grading. Then what are the other advanced, any other advanced tools? What we will ask? Anything we can ask ENT surgeons to do?
Ideal, ma'am. Indirect
Yes.
laryngoscopy, ma'am.
Laryngoscopy
For
and
movement
if
of vocal cords,
available,
ma'am.
sonography.
Yes, ma'am.
Sonography also. USG. And how USG can help you?
Ma'am, by UHG, we can see vascularity of the structure and ma'am,
We can see the
It is not.
patency of the airway.
So if in USG you have to see arytenoid, right? If arytenoid it is in same, then there will be no nerve palsy. If it is a means one arytenoid is above, then there may be, you can suspect compression and laryngeal nerve palsy also, right? Then you can also have an idea of which type, which size of tube you can able to negotiate, because there is a huge goiter and there is a compression over the trachea, and your trachea is also deviated, right? So
Yes.
you have to ideal and USG, if available, you should always do before planning for the anesthesia. Okay.
Ranashni, which type of endotracheal tubes you will be using in thyroid surgery?
Yes, ma'am. We commonly use reinforced armored flexometallic tube, ma'am, which are kink resistant, ma'am, as we are sharing the airway place with the ENT surgeon, ma'am. And also, ma'am, we can use a North Pole or RA tube, ma'am. And if not, ma'am, we can also use, ma'am, nerve, if there is a, if we want to share for nerve monitoring, ma'am, for recurrent laryngeal nerve, we can also use nerve integrity monitor tube, ma'am.
What does that tube denote? What does it indicate?
Yes, ma'am. Ma'am, the tube indicates the ma'am, the tube we use intraoperatively, ma'am. It has 2 electrodes. One electrode is placed on the glottis, ma'am. Other is placed on the sternum, ma'am. We can do recurrent laryngeal nerve monitoring with the help of that tube, ma'am. It has an electromyogram which shows the monitoring, ma'am. If intraoperatively there is damage to the recurrent laryngeal nerve, ma'am, or not.
So you use it mostly in massive retrosternal goiters or huge thyroid swellings?
Yes, ma'am.
Yes.
Okay.
Ma'am, I'll share for the image of the tube, ma'am. This is the
So intraoperatively, you can find out whether there is a movement of that, which side of recurrent laryngeal nerve is. Okay.
Yes.
And what is the position you give for this patient for intubation?
We used to do a rose position in which one bolster is placed under shoulder blades and head is extended, neck is extended with the head ring. Patient is slightly 10 to 15 degree head up, for which easy venous drainage is there and exposure is better for the surgeon.
Your choice of pre-medication in this case? Pre-medication.
Yes, ma'am. We have used ma'am midazolam and fentanyl and anti-sialolol and glycopyrrole.
Okay, so what precaution you will take while giving midazolam and fentanyl? Because this is a huge goiter. There is a
And
chances
there are
of
collapse of
Collapse.
airway, ma'am. So
Ma'am, the thyroid swelling can fall, which can collapse, and the epiglottis can fall upon it. So we'll ask the assistant to come in the front, and while intubating, he'll hold for the swelling, and then we can easily intubate it. Take care
while
of
giving
this.
pre-medication also you should be cautious, right? If you
Yes,
are
ma'am.
giving the sedatives and don't give in the pre-anesthetic area where the means without monitor. And you have to, if at all you want to give the sedation, then you should be cautious. There are chances of and there are means chances of tracheomalacia and airway compression is there. So
Okay, Dhanashree, whatever the airway plans you had done and pre-medication has been given, which are the intraoperative monitoring required for this type of surgery?
Yes, ma'am. When the patient comes inside the OT, we'll need all the basic multi-para monitor, ma'am. SpO2, ma'am. Pulse ox, BP, ma'am. ETCO2, ma'am. For ECG and ma'am, I will also, Baki, ma'am. If we want, we can also add for arterial line if the patient is having a retrosternal extension, arterial line monitoring.
Generally, routine thyroid surgeries doesn't require invasive monitoring, but if the patient is hyperthyroid, requires emergency intervention or with high vascularity, patient is not having a time to stabilize the vascularity control. At that time, we can plan for the invasive monitoring, right? And one
Yes, ma'am.
thing you missed that temperature monitoring is required.
Yes, ma'am.
yes,
Okay.
Yes, ma'am.
So why temperature monitoring is important for thyroid surgery?
In case of hyperthyroid patient or hypothyroid patient, ma'am, intraoperatively, if hyperthyroid patient goes in thyroid crisis, so to diagnose it, we will need temperature monitoring, ma'am. Patient primary thing is the patient will go in tachycardia and hyperthermia, ma'am. In case of the hypothyroid patient, he can go in hypotension, bradycardia, and hypothermia, ma'am. For that reason, we'll need temperature monitoring.
Okay, so temperature monitoring is must. Okay.
would you
Yes,
like
ma'am.
to put
Apart
would you
from
like to
this,
put rice tube in this
Yes,
patient?
ma'am. Yes, ma'am.
we
Then
need
you have
to.
to mention it, right? Ki I will put
Yes,
rice tube. Okay.
yes,
Yes,
What are
ma'am.
the
ma'am.
advantages of means what are
Ma'am,
the benefits of putting rice tube?
ma'am, since the anti-thyroid drug, all the anti-thyroid drug preparations are in oral form. So in
Yes.
intraoperative in thyroid crisis, we can always crush the propyl thyroid uracil tablets and give it some rice to me.
And if you will want to give cold wash and cold
Cold
saline
wash. Yes,
in
ma'am.
case
Yes,
of if patient is
Thy-
having crisis,
Thyroid.
then you can give uh, wash also,
in
cold
the
saline
monitoring,
wash also. Okay.
yes, ma'am.
also in the monitoring, would you like to add neuromuscular monitoring?
Mm.
Yes, ma'am. Ma'am, we'll for monitoring, we attached our patient with this monitor, ma'am. For seeing for the
How will
depth of
that
ma'am.
monitor help you? How will that monitor help you?
Yes, ma'am. It will assist for the depth of anesthesia, ma'am. We usually assist with the BIS monitor, ma'am. There are 4 grades, ma'am, for BIS monitoring, ma'am. There is classification, ma'am, for that. Usually between 40 to 60 score, the patient is under a deep, well settled general anesthesia, ma'am.
I'm not asking about the base monitoring. I'm asking about neuromuscular
Neuromuscular.
monitoring. Okay.
Yes, ma'am. For
Yeah.
TOF monitor, we can go for TOF monitoring,
Yes.
ma'am.
How is
3
that
or 4.
useful to you?
Ma'am,
Hyperthyroid or
usually in
this
hypo.
huge swelling?
Yes, ma'am. In hypothyroid patient, ma'am, there are very chances that they can go ma'am, they will have a depressant effects, ma'am. Due to which, if we administer large dose of muscle relaxant, there are chances that patient will not come out. So whenever the patient comes out at that time only, adequate doses of muscle relaxant should be given. So neuromuscular monitoring will help us with that, ma'am.
There are many autoimmune disorders associated
Yes,
with
ma'am.
either hypothyroid
Myasthenia.
patients and hypothyroid patients. So you need it for that. Like Hashimoto's thyroiditis, that is autoimmune thyroiditis. So it can be helpful to you for that purpose. Okay.
Which is the
This
other
monitoring not
condition?
only for the depth of the anesthesia, other way how it helps intraoperatively.
Yes, ma'am. We have PRST score, ma'am, in which we see for blood pressure, ma'am, heart rate, and sweating and tremors, ma'am. So according to scoring, by this monitoring, we can assess for all the scores, ma'am.
And what it helps to diagnose is any complications arising intraoperatively.
Yes, ma'am. Ma'am, if the if the tachycardia or if there is sudden tachycardia, sinus tachycardia in operatively or any, so we can judge then whether patient is in a lighter plane of anesthesia or this is thyroid crisis.
And how will you diagnose the thyroid storm intraoperatively under anesthesia?
Yes, ma'am.
Thyroid storm.
First,
How will you
yes,
diagnose thyroid
there will
storm or
be.
crisis?
Yes, ma'am. There will be, ma'am, there will be tachycardia, hyperthermia, ma'am, and ma'am, there will be exhaustion of exhaustion of soda lime with increase in EtCO2, ma'am, and soda lime canister will become hot, ma'am. In this way, we can diagnose for the intraoperative.
So what is the differential diagnosis? This
Ma'am,
also
differential
happens with the
can be malignant hyperthermia, ma'am. But malignant hyperthermia usually presents with masseter spasm and muscle rigidity, ma'am. And it happens usually after induction, within minutes or seconds of induction. So we can differentiate it with the thyroid crisis that whenever a surgeon is manipulating thyroid gland at that time, if we are seeing such symptoms, ma'am, then we can say that it is thyroid crisis, ma'am.
And we can always do blood investigations after that. Malignant hyperthermia, there is rise in creatine kinase. So
once you diagnose the thyroid storm, how will you manage that patient intraoperatively? What is the management sequence for this patient?
yes, ma'am. And firstly, we will manage the adrenergic effects of the thyroid hormone. That will be done by non-selective beta blockers, or we can use selective beta blockers like esmolol. And then when we used to prepare a patient with the anti-thyroid drugs, which we can give through Rios tube. That is propyl thiouracil or methimazole or carbimazole. And for hyperpyrexia, we can use paracetamol. And for non-specific management, we can use cold saline lavages should be used for hypothermia. And
Ma'am, we can also add steroids or injection hydrocortisone 300 mg IV for adrenocortical deficiency, ma'am.
Yes. First of all, you have to ask the surgeon to stop the surgery. Then you have to do everything. Okay. And other than the temperature, which type of arrhythmias or pulse rate variation in the thyroid storm or thyroid crisis?
Yes, ma'am. Most common is tachyarrhythmia, ma'am. But after that, if patient goes in arrhythmia, then a patient can go in atrial fibrillation, ma'am. Where in ECG we can see absence of P waves, ma'am. So for
irregular rhythm.
Ma'am, for management of that, we can give, ma'am, first of all, we'll manage for the pulse, ma'am. We'll give beta blockers, ma'am. Choice will be injection propranolol. After that, we'll give amiodarone, ma'am. 300 mg IV stat, followed by 150 mg over 6 hours, ma'am. And if patient is not settled, we can go for diltiazem also, ma'am.
So is the role of the digoxin in the management of the atrial fibrillation at the time of thyroid crisis?
Yes, ma'am. Digoxin, we can do digitalization of patient, ma'am. If there is crisis, we can do. There are two types of digitalization, ma'am. Slow and fast, ma'am. If there is crisis, we can go for fast digitalization, in which we give 0.75 mg to 1 mg IV stat, ma'am, to the patient, followed by 0.25 mg 6 hours, ma'am. A maximum we can go up to 10 mg, ma'am. And in slow, we give 0.125 mg to 0.25 mg, ma'am. IV stat followed by 0.125 mg 6 hours, ma'am.
Dhanushi, what is the role of amiodarone in thyroid patients? What are the clinical implications of using amiodarone?
Yes, ma'am. Amiodarone is antiarrhythmic, ma'am. Ma'am, it is a potassium sparing diuretic. And class
The
3
class
and
3 anti-arrhythmic.
class 3
Okay.
antiarrhythmic, ma'am.
Yes.
But it contains iodine. So
What
It
is its
comes in the
mechanism of
form
action? What is its use in thyroid patients?
ma'am,
for prevention of arrhythmias, ma'am.
if a patient is in first use when patient is atrial fibrillation, we can always use amiodarone. And ma'am, in since it is a iodinated drug, so it can produce hypo or hyperthyroidism or even crisis.
So amiodarone can cause hypothyroidism. So it's also called amiodarone-induced hypothyroidism also. Okay.
Yes.
Okay. Which are the other arrhythmias you encounter apart from atrial fibrillation, which are less common?
Ma'am, ventricular fibrillation.
Ventricular tachycardia and ventricular fibrillation. Okay. So you have managed the case, and you were telling that suppose you are all alone in peripheral hospital and you are not having reshow, you are not having, you have prepared everything, you are not having fiber of scope. So in used thyroid, which one thing you have to keep in your trolley preparation?
Ma'am, we will ask ENT surgeon to get ready with rigid bronchoscope.
Yes, rigid bronchoscope is needed. Okay. Slide like it. Dhanushree, are you connected, Dhanushree?
Yes, ma'am. Yes, ma'am.
Yeah. Complication intra and what are the other intraoperative complication you will face and postoperative complication? Immediate and late complications.
The most important intraoperative complication we can encounter in an unprepared patient is thyroid storm, which and in when
Mixed
postoperative
edema coma. How will you diagnose mixed edema coma?
when mixed edema coma, primary symptom is bradycardia and hypotension, and which we can and there is hypothermia which can encounter in intraoperative period.
Okay, so mixed edema coma, if you have diagnosed, so how will you treat that mixed edema coma patient?
Then we will use Riles tube for administration of thyroxine, or if we have IV preparation of L-thyroxine, then we will use that. And if we have triiodothyronine IV preparation, then T3 administration is more suitable for this patient.
We can also get supportive measures, ma'am, like warming
Of the patient, or for adenocortical insufficiency, we usually give hydrocortisone 100 mg or dexamethasone 2 mg in every 6 hours.
Yes. How will you check the vocal cord movements at the end of the surgery?
When we can do conventional laryngoscopy in a patient should not be in lighter plane of anesthesia, which can give rise to laryngospasm, or we can use supraglottic airway devices. With the help of fibroscope, we can detect the movement of vocal cords. And
we can also use video stimulate, ma'am, for the same purpose. And other thing is that if our patient is light and conventional scope is not possible and patient is extubated, then we can go for phonoletter to check for the patency of vocal cords.
One thing
Patient
before, one thing before extubation, what you would like to test as your patient is having retrosternal goiter? No,
Cuff
no
leak.
retrosternal, but huge goiter, right?
Yes, ma'am. We'll check
Anything
for
you would like to?
cuff leak
cuff
test,
leak
ma'am.
test.
Yes. So, what is leak test and how will you perform it?
when we deflate the endotracheal tube cuff, then we should hear the leak, or which we can hear clinically or with the help of stethoscope. If there is no leak present, then there is edema around the uh, around the
Uh, First of all, we record for tidal volumes, ma'am, with inspiration and expiration, ma'am. Then when the cuff is deflated, ma'am, then we deflate the cuff and then we look for again tidal volumes for during inspiration and expiration for 6 cycles, out of which 3 cycles, where when there is lowest tidal volume, we record that, ma'am. And the difference between inflation and deflation tidal volume, ma'am, with that we'll come to know if the cuff leak is more than 110 ml or 10 to 20% of leak is present, then the cuff leak test is negative, ma'am, which is good. That means leak is present, ma'am.
So leak should be present before
present.
the extubation. Otherwise, there are chances of tracheomalacia, right?
Tracheomalacia. Yes, ma'am.
In case of tracheomalacia, what precaution you will take before the extubation if your leak test is negative,
Negative.
right? Then what you
Ma'am,
will do?
if there is tracheomalacia, when we will not extubate the patient, we will wait for 48 hours to again test the cuff leak test. And after 48 hours, so there is cuff leak test is still negative, then we will perform elective tracheostomy.
Can you proceed with the Cook's airway exchange catheter before extubation?
Yes,
ma'am.
Ma'am, we can pass the catheter to the from the tube, ma'am, and we can do with the railroad technique. We can pass the catheter and then we can look, ma'am. Cook's airway exchange catheter, we can attach for the O2 supply, ma'am, so that patient will have a oxygen, ma'am. Airway will not collapse with the catheter, ma'am. And if there is need for reintubation, we can again put the tube, ma'am, with the help of catheter.
And after checking that vocal cord movement is not adequate, right? So how will you diagnose the vocal cord palsies? Can you describe that?
Ma'am, if vocal cord pulses in a neutral position between abductor and adductor position, then there is a bilateral complete vocal cord injury. And if the patient, if partial, if RLN palsy is partial on bilateral side, then there will be a complete closure of a glottis due to overaction of adductor muscles in the absence of abductor muscles.
Ma'am, usually we need urgent intubation or tracheostomy for such patients, ma'am, because both the cords are adducted, ma'am.
Which
Out
is
of all
most
four?
dangerous?
Yes, which is dangerous.
Selective abductor injury on the bilateral side is more dangerous than complete.
Okay, so for
So partial.
that you have to, and
Yes, ma'am.
if it is patient is having a last one, the complete, then
Yes,
one advantage is patient's airway is patent, but what other complication patient will get?
ma'am, aspiration risk is there.
So you have to
Chances
take
of
care of
aspiration.
it. Hmm. Suppose your patient is extubated, you have seen the patient, everything is good. After extubation, suddenly you got a call from the ICU that patient is having stridor. So how will you manage? What are the causes?
Ma'am, most important cause may laryngospasm. Second is laryngeal edema. There may be hematoma collection in the recent operated procedure. Ma'am. There may be tracheomalacia and
Recurrent
Tracheomalacia you have seen. Okay.
hypocalcemia, we can also suspect for if delayed
Yes.
complication with 36 to 48 hours within. We can see.
induced laryngospasm may be there.
How will you manage hypocalcemia?
Ma'am, for that
How
pre-operative,
will you diagnose that?
Yes, ma'am. Ma'am, in symptoms and there will be
Post-operative hypocalcemia.
in symptoms and there may be circumoral numbness, tingling in the fingers, and positive signs like Troche's sign or Shepard's signs. Then we can always send lab investigation where serum calcium is is measured, and we will make out the corrected calcium levels with the help of serum albumin. And if there is hypocalcemia, we can use a calcium gluconate, 1 gram 10 ml preparation of 10% solution, or calcium chloride.
How much
Can you
dose?
explain the pain management in such type of huge thyroid surgery?
Yes,
Yes,
ma'am.
we can go for regional anesthesia like superficial cervical blocks or deep cervical blocks, and intravenous paracetamol, or
How
if
will
patient is
what are the methods? How will you give superficial cervical and deep cervical plexus block?
Yes, ma'am. Superficial cervical plexus block, and we can give landmark guided, but for deep cervical plexus block, we should not. For deep cervical plexus, not, ma'am, we should give it with the help of USG, ma'am. In superficial cervical plexus, ma'am, give me a minute. I'll share for the landmarks, ma'am. Yes, ma'am. Superficial cervical plexus block, ma'am. We go for the posterior border of sternocleidomastoid, ma'am. And from here, we can block, ma'am, lesser occipital nerve, greater auricular nerve, transverse cervical, and supraclavicular nerve block, ma'am. Usually, we give 3 to 5 ml of 0.25% to 0.5% bupivacaine, ma'am. And in deep bilateral, we can give for bilateral superficial cervical block, ma'am. But for deep cervical plexus block, ma'am, from mastoid process, ma'am, we go towards the posterior border of sternocleidomastoid. And ma'am, we insert the needles at a transverse process of C6 vertebra, ma'am, USG guided, and we can inject the drug at multiple level, ma'am. At 3 to 5 ml, 0.25% to 5.5% bupivacaine can be used, ma'am.
okay.
Unilateral, we go for unilateral deep cervical plexus block, ma'am.
Yes.
And there can be complications, there are more complications with deep cervical plexus block, ma'am, like phrenic nerve palsy or epidural or intrathecal injections, ma'am. And also last can be there. The injection can go in vertebral artery, ma'am.
Is surgery possible under regional anesthesia?
Well, surgery can be performed under cervical epidural anesthesia, but it's more dangerous, and we need to be very vigilant in that.
Yes. Hmm.
So suppose your patient is coming for, patient is hyperthyroid and posted for non-thyroid surgery. So at that time, how will you manage? Which anesthesia you prefer?
Yes, ma'am. First of all, if it is non-thyroid surgery and if it is elective, I'll go for first. I'll make for 6 to 8 weeks. I'll make the patient euthyroid. I'll start with ma'am anti-thyroid drugs and like propylthiouracil, ma'am. And then I'll go after 7 to 14 days before I'll go with iodine, ma'am. And if a patient is tachy, I will also go with injection propranolol, ma'am, for sympathetic blockade. During surgery, ma'am, during induction, I will prefer I will avoid sympathomimetic drugs like ketamine, atropine, and panlocurium. I will go for thiopenton and propofol, ma'am. Thiopenton has added
So that
advantage.
pentothal is better or propofol is better?
Ma'am, pentothal is more better, ma'am.
It inhibits the conversion, ma'am, T4 to T3.
T3 conversion.
Okay. Okay.
And
And
then
intraoperatively, inhalation, which inhalation agent you will give?
sevoflurane is the inhalation agent of choice, ma'am, because it is cardiostimulator. Halothane, which can cause hepatotoxin.
And if hypothyroid patient, so do you like to give the regional anesthesia for non-thyroid surgery? And what are the advantage of regional in hypothyroid patients?
Yes, ma'am. In hypothyroid patients, ma'am, the patient goes towards depressant activity more. So, if we give scoline or muscle relaxant, there are chances that patient may go into mix it depression, and then patient may not get extubated because it will not come out. But if we go for regional anesthesia during hypothyroid patients, so it will be easy for patient. There will be no risk of depressant activities, ma'am.
Okay. So hypothyroid patients are more prone to delayed recovery.
Yes, yes, ma'am.
Because you avoid sedatives in that patients. Okay. Okay. So how will you know about hypothyroidism and hyperthyroidism in pregnant patients and management? And what are the anesthetic implications?
When in hypothyroid pregnant patients, we will we will treat the patient with thyroxine, and if patient has to be taken for emergency cesarean section, then we will prefer regional anesthesia, then general anesthesia. And in hyperthyroid
Thyroid medication is preferred.
thyroid medication,
Levothyroxine.
levothyroxine. Antithyroid, if patient is hyperthyroid, we will prefer propylthiouracil because it is less, it is not teratogenic as methimazole, and the drug of choice in pregnancy is propylthiouracil, which can uh, which does not cross placenta, and fetus fetus does not present with cretinism at birth.
Okay, so there are less chances of congenital hypothyroidism in the newborn. Okay.
Yeah.
Okay.
In patients who are on antithyroid drugs, the fetal ultrasound for thyroid hypoplasia is also done.
As such, thyroid discussion is very vast topic, so we cannot conclude in very short time. But we had faced another patient, a very crucial patient with very huge thyroid, uh, come with a strider in the emergency. And at that time, in emergency, we have no video laryngoscope or no any gadgets for the man. So we lift the thyroid gland by other person and intubated, and we stabilize the patient in the emergency for at least 10 to 12 hours and manage. And then next day, this patient is operated for the thyroid surgery. And uneventfully, patient was extubated because even though this huge thyroid in patient with stridor, after 1 hour of the completion of the surgery, patient can able to maintain the airway and we can able to extubate the patient. There is
This was
one question in the chat box: the difference between the primary and secondary hyperthyroidism and treatment. Can you explain it?
Yes, it is an important question.
Primary hyperthyroidism is pathologies in the hyperthyroid gland only, and there is more of a CNS manifestation than eye signs. Since CNS manifestation, patient is anxious, the patient is anxious, restless, agitated, and there may be confusion in for the patient. And in eye signs, the more of the signs are present, like exophthalmos, von Graffi sign, lid retraction, and proptosis.
It is because of CVS manifestations, ma'am, and it is because of dysregulation between the HPO axis, ma'am. Out of the thyroid, the reason for hyperthyroidism is beyond the thyroid gland, ma'am.
And manifestations are more on the serious. Patients present with palpitations, hypertension, and dysarrhythmias, and most commonly is sinus tachycardia, and after that, atrial fibrillation may be there.
Another question is regards to USG. So they've asked it, what is use of USG for diagnosis of tracheomalacia? Dhanashree?
Yes, ma'am. In USG,
one thing is you are doing the cuff test.
position.
Second thing,
Yes, ma'am.
yeah. Second thing,
ma'am,
the surgeon can also feel the tracheal rings. If he feels
Yes,
that, he will say that you cannot, you have to see leak test, surgeon, and another, you can get help of USC.
Yes.
Okay. One question is that sometimes the trachea is damaged during thyroid surgery. So how will you manage? I mean, sometimes they will take stitch with the tube also. So you cannot extubate the patient. Once it happens with me.
Ma'am, in such cases, we will defer for extubation, and then we'll
Take the patient inside the operation theater again and explore the patient.
we'll go for
It is
tracheostomy.
Okay,
elective
since
tracheostomy.
we have to keep the endotracheal tube in situ and elective ventilation till that recovery will occur. Okay. After that, you want to extubate or something.
And sometimes maybe there may be extension of intraluminal extension of thyroid also. So USG will help to diagnose that extraluminal means intraluminal extension also.
Yeah.
Yes.
Yes.
Other question is, Dhanashri, what is sick euthyroid syndrome?
Yes, ma'am. In sick euthyroid syndrome, ma'am, the cause of the patient's TSH profile, ma'am, is ma'am increase in patient is euthyroid, ma'am. All the thyroid profile is normal, but then still there is increase in T3, T4, ma'am, because the peripheral cause is present. That is reverse T3 is increased, which is inactive form of T3, ma'am. Usually during sepsis, shock, or in heart failure, if patient is there, or in anemia or starvation, there is extra peripheral conversion of T4 to T3, which causes the thyroid gland to make T3 inactive, which presents in the form of reverse T3, ma'am. So other all profiles are normal except for reverse T3, ma'am. It increases. That is the significance.
Reverse T3 ma'am also inhibits the activity of triiodothyronine, which seems like ma'am sick euthyroid syndrome despite of normal TFTs.
Okay. So, Kanvi, do you have any more questions? Dr. Kanvi?
No, ma'am. No, ma'am.
No,
Regarding
good
medical
presentation
management,
and
It was
also
a very good presentation, and both
yes.
case scenarios were very good.
okay,
And
one
that
last question
madam
to
has showed
Dhanashri.
the slide of that huge thyroid which is managed in ICU
Emergency.
casualty. It is also a very good
It was
means good
excellent.
case to share. Thank you, madam.
At this outset, I would like to thank Dr. Hina Chanwal, who has been present since long, especially to our online CME. Thank you, madam. She is the GC member national of ISA.
Thank you, Mangal Bhai,
And
that you are given a video medical college.
Ji, madam,
Mangal Bhai,
thank you.
thank you for giving opportunity to PDU Medical College students for the
Oh,
presenting the
madam.
case. For first case presentation.
Thank you, Manna madam. Thank you, Lopa madam. Thank you, Kanvi madam, Chigisha madam, Vrinda madam, and both the students who did excellent job of presenting these cases. It was very much informative for us practitioners also, and I hope it has very much benefited. It is very much beneficial to all the students who have witnessed it. And please spread the message to all the other students also. And I hope in future CMEs there will be a more and more number of students will get involved, and sharing of knowledge will be done.
Thank you. Thank you very much. Thank you, sir. Thank you.
Congratulations to congratulations to
Thank you, sir.
Mangal Dave sir and whole team. Very excellent presentation by these two PGs. Even we are fail in all these things because there was no much teaching in our days like this type of the teachers are excellent. Their presentation and their questions step by step is very good. Hoping that same and much more good levels of CME will be conducted in future, and Gujarat ISA will be boon in national levels, because we are lacking. They all says that Gujarat is lacking for academics, but they don't know our potential. Teachers and students are there.
Agree.
Excellent presentation.
Thank you,
Very
sir.
nice. Thank you, Tarun sir. Thank you very much for the inspiring words. Vandana madam, anything for conclusion?
No conclusion, because topic is very wide and we cannot cover up all the things altogether. But we try to just
highlights some points that is very much important for the student point of view. But cases are all the cases are different at different ways.
Yes.
Sometimes plan fails, and we always have a backup plan also. So students should be ready at any time for the plan B.
Yes.
Yes.
Thank you very much.
Thank you.
Thank you.
Thank you
Thank
all.
you.
Thank you.
Thank you, Mangal sir. Thank you.
Jayesh bhai, thank you
We
very
thank
much
our
for being the
residents
host.
also.
Jayesh sir, thank you very much for being the host of the event. Without you, your technology, we would not have been possible to do this CME. Thank you, Jayesh sir.
Ready for this making this technology study and the YouTube live streaming, and I am sending all these details to you. Recording.
Yes. Thank you, sir. Thank you.
Thank you.
So we conclude this CME. Thank you all. Thank you very much.
Thank you. Thank you.
Thank you. Thank you, sir.
Thank you.